The disorders from glucocorticoids, Cushing's syndrome, is pretty much synonymous with the term hypercortisolism. Now, things become difficult sometimes when people break the words up into primary and secondary. It's very hard to understand. It's confusing. So when we say hypercortisolism, first thing we have to do is say, hey, is this hypercortisolism or not? So first we want to say, do you have hypercortisolism? Next we say, where's the location? So Cushing's disease generally refers to Cushing's hypercortisolism that's coming out of an adenoma of the anterior pituitary. Now, hypercortisolism can also come out of the adrenals, and there can be an ectopic focus somewhere. So basically, hypercortisolism can happen in three separate locations. The pituitary, where it's an adenoma of the anterior pituitary making ACTH. The adrenals, where it's often either an adenoma or hyperplasia of the adrenals. And the third is cancer or ectopic focus in some third location, usually the chest. So the first step is to say, do you have hypercortisolism? And that means that we take a look and we see that the cortisol levels are really elevated. So in order to do that, we have to say, do you suppress with dexamethasone? Do you have a high 24-hour urine cortisol? Do you have a high late-night salivary cortisol? Then the ACTH levels are used to establish the location. First, do you have hypercortisolism? Number two, what is the location? So the first of the tests, a 1 milligram overnight dexamethasone suppression test, what would be the normal response? If I gave you a milligram of dexamethasone, and dexamethasone has the greatest glucocorticoid activity of all the steroid hormones. If I tell you that you have a high 1 milligram overnight dexamethasone suppression test, that the cortisol level in the morning is high, is that normal or abnormal? If the morning cortisol is high, that would be abnormal. Since dexamethasone at night should suppress it, the normal is morning suppression. And now, if you have hypercortisolism, you will not suppress. So this is to establish the presence of hypercortisolism regardless of the cause. A normal is that the cortisol level should go down. The abnormal is it doesn't go down. And it tells you if there's hypercortisolism. The problem is there's false positives. A normal one, meaning suppression, excludes hypercortisolism. An abnormal one can have false positives because what's the difference between monsters attacking you and the monsters in your head attacking you? A high-dose dexamethasone test tells you the difference between pituitary adenomas and ectopic ACTH. In other words, high-dose dexamethasone should be able to suppress the pituitary, and ectopic foci will not suppress the pituitary. Once you establish that you in fact have hypercortisolism from a 24-hour urine cortisol, now we want to say, okay, where's it from? Where's it from? Where's it at? So after the hypercortisolism is established from the 24-hour urine cortisol, then we can use the ACTH level to say, well, did it come out of the pituitary or not? If the ACTH level is high, it could be out of the pituitary or an ectopic focus. If the ACTH level is low, it means it's in the adrenal. In the adrenal means that the adrenal is making cortisol and having feedback inhibition on the pituitary. A low ACTH means the adrenal is making the cortisol and having feedback inhibition on the pituitary. If the ACTH level is high, it could be pituitary adenoma or some ectopic focus. And how do we tell the pituitary and the ectopic focus? With a high-dose dexamethasone. High-dose dexamethasone should suppress the pituitary, but not the ectopic focus. The ectopic focus could be a carcinoid. It could be a cancer. Cancers are not under feedback inhibition. Cancer's like, I'm not suppressing for you. Don't bother me, man. I don't care how much dexamethasone you give me. I'm not going to suppress. You cannot suppress me, says the cancer. But the pituitary is just hard of hearing. When you yell at the pituitary, would you suppress? Then the pituitary says, okay, all right, stop yelling. Now, the opposite of Cushing's is Addison's disease. And with Addison's, we want to say, okay, well, is your adrenal glands having like male pattern hair loss of your adrenals? You know, they just sort of fuzzed out and not working. So ACTH should be able to stimulate your adrenals. You test the cortisol level before and after giving ACTH. And a normal person should have a bump up in cortisol in response to ACTH. So a normal person bumps up. And what ends up happening is that if your adrenal gland's not working, your cortisol level will not bump up. So if you have a dead adrenal, giving ACTH won't do anything. A normal person should bump up their cortisol. An abnormal person will not bump up their cortisol. That's sometimes known as Coltrane stimulation. ACTH, what is artificial ACTH, is Coltrane. And that's what should be the normal effect. The normal effect is it should bump up the cortisol level in response to giving ACTH. Should bump up the cortisol level in response to ACTH. Now, primary hypercortisolism means basically it's coming out of the adrenal gland. It's independent of ACTH. The cortisol is up, the ACTH is down, and primary hypercortisolism is the same thing as saying adrenal hypercortisolism. And when we mean by benign, meaning it doesn't metastasize, it's just like an adrenal gland with a personality disorder. And it just won't listen to feedback. You see, failure of feedback inhibition is a disease. Failure of feedback inhibition is a disease, and it's mostly benign adrenocortical adenomas. So failure of feedback inhibition ends up being a disease because the ACTH should, when it's suppressed, should shut off. I mean, there should not be any cortisol going on. When the blood pressure is up, it should not be any cortisol. When the sugar is up, there should not be any cortisol. When the blood pressure and the sugar is up, there should not be cortisol, but there is. It's usually a unilateral adrenal adenoma, and the management of this is just cut it out, get rid of it, slice it out. Now, there's androgen and mineralocorticoid excess, but you don't have to have carcinoma, but cortisol at excess amounts will also have some androgen and mineralocorticoid effect, meaning at low levels, it's just sugary and glucose, glucose, sugar, and fat. But at excess amounts, there'll be some androgen effect as well, and also some sodium effect, so the blood pressure is up. So you'll see both the hirsutism and the acne and blood pressure up too. Now, ACTH-dependent hypercortisolism means that you can have it from hypersecretion from the pituitary, and you get bilateral hyperplasia of both the fasciculata and the reticularis, because remember, both the fasciculata and the reticularis are under the control of ACTH. And so therefore, you will get androgenization, so you'll get acne, male pattern hair loss, hirsutism. You won't notice any of them in men. You won't notice any of them in men, but you will notice it in ladies. And you'll have growth of the fasciculata. ACTH will be up, cortisol will be up. And the cortisol will therefore raise the sugar, raise the free fatty acids, and destroy proteins. Often you get muscle abnormalities because the muscle is destroyed to make sugar out of it. Steroids are very damaging to your muscles in the long term. Glucocorticoids make you feel good for a little while, but after a while they consume. It's like living on your credit cards. It's like makes you feel okay for a while, and then you max out. When it's in the pituitary, it's a microadenoma. Remember, microadenomas are in general more common than macroadenomas. The ACTH won't necessarily cause you to have hyperpigmentation, because hyperpigmentation comes when there's the whole molecule of pro-opiomelanocortin, then the whole molecule of pro-opiomelanocortin. Now, this ACTH generally doesn't have the hyperpigmentation, because when you have pituitary adenomas making ACTH, It's really just the ACTH portion of it, not the pro-opiomelanocortin. And under high dose, the pituitary will suppress. It's very hard for people to get that. I didn't get it when I was a medical student. When I was a medical student, I just didn't understand. It seemed like one big mess of tests to me that I couldn't understand at all. So that's why we're going to go back and say these again. Hypercortisolism is diagnosed by 24-hour urine cortisol, 1 milligram failure to suppress with 1 milligram overnight dexamethasone, or a high late-night salivary cortisol. Those three tests are to establish hypercortisolism. ACTH testing and high-dose dexamethasone are to establish what's the origin, where's it from. Pituitaries suppress and ectopics don't suppress. That's the bottom line. Pituitaries suppress and ectopics don't suppress. Hypercortisolism is established by lack of control with the 1 milligram overnight or elevated 24-hour. If you suppress with the 1 milligram, you don't have hypercortisolism. If you suppress with the 1 milligram, you don't have hypercortisolism. Now, the problem with this is that ones that fail to suppress are sometimes people who are just anxious. What if you've got somebody who's an insomniac or someone who's anxious and stays up all night and then it doesn't suppress? It's because they're just being anxious all the time. Well, then that's a good reason, or alcoholic and depressed. There are many psychological reasons to fail to suppress. Now, if there is a low ACTH, it means it's coming out of the adrenal. A high-dose dexamethasone will suppress ACTH if it's in the pituitary and will not suppress the ectopic foci. You can't tell what the origin is of the Cushing's disease or hypercortisolism just by seeing moon face and buffalo hump and truncal obesity and stria. That happens in all of them, pituitary, ectopic, or adrenal sources. Protein depletion happens from all of them because all of them result in cortisol melting your proteins. And all of them will have an anti-inflammatory effect of the cortisol, poor wound healing. Why do you have poor wound healing? Is that, well, wounds are healed by making new protein to sew up your wounds. But if the protein is now being consumed up and being used by cortisol to make new sugar, you won't heal the wounds. And hyperglycemia leads to a big insulin level and increased insulin resistance because basically cortisol is acting as an anti-insulin. So since cortisol is acting as an anti-insulin, what you're going to get is you're going to get a high insulin level in response to the insulin resistance. The major point here is you can't tell the etiology of Cushing's or hypercortisolism. You can't tell whether it's pituitary, adrenal, or ectopic just by looking at people. You just know they got the disorder, but you can't tell why. Why does everybody with hypercortisolism have hyperlipidemia? Because cortisol breaks down lipids in storage, such as triglycerides. Is that the same thing as saying there'll be high ketones? Why, yes. You would be, because it's an anti-insulin. So if insulin makes the lipid level low, and insulin makes ketones low, Cushing's and hypercortisolism will raise free fatty acids and raise ketones. If insulin helps form protein, hypercortisolism breaks down protein and bones as well, because bones are predominantly protein that's calcified. It's calcified protein. Why do you get stria? Why do you get breakdown of skin? Because skin is collagen, and collagen is largely protein. So you get androgens because androgens also come out of the adrenals and will result in acne in men and women. Hirsutism is also only visible in the women. And amenorrhea because the androgens suppress the periods. So in men, you actually can get an abnormality on causing abnormal feedback inhibition on the pituitary. Now, mineralocorticoids will also occur, the mineralocorticoid effect, because the effects of these hormones are not exclusive at high levels, meaning that mineralocorticoids at very high levels, the aldosterone, might have a little glucose effect, and glucocorticoids at high levels have some mineralocorticoid effect. That's why it is that cortisol at high levels will cause hypertension. You'll have salt and water retention, you'll have potassium loss, because it'll start to act like a person who's got Conn syndrome, hyperaldosteronism. And you have increased thirst and polyuria as well, because you start to have high sugars, and you start to have these high sugars causing volume depletion by making you lose out your sugar from your kidneys like you would in a person with DKA. The other thing about cortisol is that under high amounts, there is a psychosis from it. You can get anxiety, depression, and actually people can go crazy from high steroids. At high dose, there's actually a steroid psychosis. It makes people nuts. When the steroids were first invented in the 1950s and people using them therapeutically, people were going outright crazy from using the steroids at high levels and developing a form of psychosis. Hypocortisolism and Addison's disease are pretty much synonymous terms. And if high cortisol gives you high blood pressure, low cortisol gives you low blood pressure. If high cortisol gives you a sodium retention and high blood pressure, Addison's disease has low sodium. If cortisol made you hyperlipidemic and hyperglycemic, then Addison's disease caused low sugar and low glucose. The ACTH levels will cause you to be hyperpigmented all over the place because of the pro-opiomelanocortin. The aldosterone deficiency part results in salt wasting and hyponatremia. The potassium will end up being retained, and you have a metabolic acidosis with high potassium. And it's exactly the opposite of what you have in hyperaldosteronism. In hyperaldosteronism, you have high blood pressure and a low potassium. Here you have a low blood pressure and a high potassium. We don't even notice the loss of 10, 20, or 30% of any organ. If you lost 30% of lung function, you do not become hypoxic. If you lost 30 or 40% of liver function, you don't get a low albumin or abnormal clotting factors. If you lost 50% of kidney function, you would not get a rise in your creatinine. For all of these organs, you need to be losing 80 to 90% of those organs before you get any clinical manifestations. We have to lose 80 to 90% of those organs before you get any clinical manifestations. There are no clinical manifestations of a loss of 10 or 20% of these organs. And that is why it is that you can only have the most severe disease by the time you have any clinical manifestations. And what ends up happening is that the only way to get this suddenly is somebody who infarcts a kidney, or infarcts their kidney and the adrenal on top of it too, the whole organ gone. So bilateral hemorrhage into it would result in adrenal crisis. And you would notice this because you'd lose blood pressure and have high potassium. So you'd have low blood pressure and high potassium, and that would be consistent with acute adrenal infarction. But in order to have the manifestations, it would have to be bilateral. You would not notice unilateral disease. It would have to be bilateral disease. Orthostasis means that when you go from lying down to sitting up, that you don't recover your blood pressure. Now, everybody's blood pressure will drop a little bit for a few seconds between going from lying down to standing, from going from sitting to standing. Everyone will have a little bit of a tachycardia for 30 seconds, and then it will recover. Orthostasis means that your blood pressure continues to be low after you've stood up, or you're to have a persistent tachycardia, more than 10 beats a minute. You have a persistently low blood pressure, 20 points lower, systolic 20 points lower than it was when you're sitting down. A persistent tachycardia, more than 10 points when you sit up, when you go standing up. So when you have insufficient adrenal, you become orthostatic because you're generally, one, volume depleted because of loss of aldosterone, and number two, remember, cortisol increases alpha-1 receptors. Cortisol increases alpha-1 receptors. So if you don't have the alpha-1 receptors, you get low blood pressure. The other thing is there's abnormalities in GI function, and you lose hair, believe it or not, because you don't have adrenal androgens. Isn't that interesting? So you have a tendency to become hypoglycemic if you don't have glucocorticoids. And you also have a tendency to retain water, but not in a good way for blood pressure. So you need glucocorticoids to be able to maintain your sugar at a normal level. Now, you can sustain the loss of, say, glucagon or growth hormone, but the catecholamines also, you'll start to get predisposed to hypoglycemia. But the loss of all your glucocorticoids will not kill you, but it'll make you very non-functional. In other words, the question will say, which one kills you? That's loss of aldosterone. But you will not have the ability to live very well or effectively without glucocorticoids. So you don't outright die, but you just have no energy to live. There are far more people who have hypercortisolism because of doctors who give prednisone than there are people who have Cushing syndrome from a pituitary or adrenal adenoma. There are many people with prescribed prednisone for asthma, for autoimmune diseases. And when you stop them too quickly, people get Addisonian instantly because their glucocorticoids are withdrawn and they get low blood pressure. The other thing is that besides trauma and various diseases like infarction, brain trauma, losing ACTH, increased demand from illness also makes people hypocortisolism. So what ends up happening is that you have to withdraw steroids slowly and taper them off over 1 or 2 weeks. Because if you don't, you also will end up having hyponatremia, low blood pressure, and that's why even when you go for surgery, you have to get an extra stress dose of steroids so that when you have the extra trauma, you don't become hypotensive at the wrong time. There's also an association with the loss of the other anterior pituitary hormones, and that's why we said that having an isolated hypoproduction of ACTH is very rare. There's usually a loss of all the pituitary hormones, such as growth hormone and thyroid-stimulating hormone and gonadotropins. And there's atrophy of the fasciculata and the reticularis because the fasciculata and the reticularis need the ACTH. The glomerulosa does not need the ACTH, so you can have, over a couple of weeks, atrophy of fasciculata and reticularis. The glomerulosa stays intact, and there's the question for you. And it actually says a person loses their pituitary. Which of the following is most likely to stay intact? Glomerulosa. A person loses their pituitary. Which of the following is most likely to be lost? Fasciculata reticularis. Straightforward, isn't it? I think so. And you can get a very severe hypoglycemia and low blood pressure. Okay, but the thing is that low blood pressure to the point of fatality will not happen as long as the glomerulosa stays intact. Fatal low blood pressure won't happen as long as the zona glomerulosa stays intact. So how do we see if the adrenal gland's intact? Well, if your adrenal gland is intact and I give you a squirt of ACTH, your adrenal gland should respond to that. So if I want to see if your adrenal gland is insufficient, I get a cortisol level before and after giving ACTH. A normal person should bump up their cortisol level. An abnormal person will not bump up their cortisol level. So the first thing to do is to get a before and after test. Let's do the cortisol, give the ACTH, and see what happens to the cortisol afterwards. A normal should bump up. So it's not that a normal result doesn't exclude pituitary problems, but it does mean that you're able to say that the adrenal's not working. See, a normal aldosterone means that it's coming out of another source, that there's a pituitary problem. If the aldosterone level were low, it means that the whole adrenal is in the problem. If the aldosterone level is normal, it means the problem's in the pituitary. So that's why the definitive test for primary and secondary is ACTH. It is increased in a person who has adrenal insufficiency or Addison's disease. Primary hypercortisolism is using the term for adrenal. So when you say the word adrenal, it means primary. Primary is adrenal insufficiency. Secondary means pituitary insufficiency. So let's say that again. Primary means that you have an adrenal problem. Primary hypercortisolism, you have an adrenal overproduction, and it leads to feedback inhibition on the pituitary. Because the ACTH level is low, there's no hyperpigmentation. Now, a secondary hypercortisolism usually means that it's either in the pituitary or it's in an ectopic focus. And telling the difference between those is based on high-dose dexamethasone testing. Primary hypocortisolism means it's in the adrenal. Primary in cortisol means the adrenal. And if we all started using terms like primary and said the word adrenal, and secondary we said the pituitary, we'd all be happier human beings. Secondary hypocortisolism means I've lost my pituitary.